uh, to, to this fourth NextGen program. We have with us two eminent professors of the country, Dr. Vel Murugan from Chennai and Dr. Simi Ratan from New Delhi. With us, we have today's presenter, Dr. Raja, who is going to present a case of abdominal mass. I request the examiners to utilize the 45 minutes of the presentation as an exam-oriented teaching, and if is not then provide answers as well. If I like able to connect my desktop on a meteorology quiz. So let's start. Thank you. Over to Dr. Raja.
Yes, sir.
You can share your slide.
Yes, sir.
Go to share screen and
Yes, sir.
I hope you have a presentation opened up.
Yes.
Yeah.
So my screen is visible, sir?
Yeah. Clear. Yeah.
Yes, sir.
Go ahead.
Shall I start? Yes,
yeah,
sir.
please.
Good evening, all. I'm Dr. Raja, third year postgraduate from Institute of Childhood, Madras Medical College. My case is a 1-year-old male child who was brought by his mother. Informant his mother, reliability is fair. Came with the chief complaints of abdominal distension for 15 days duration. The child was apparently normal before, and the child's mother instantly noticed the abdominal distension while giving birth. He consulted a private practitioner who has examined the child, and some imaging investigations were done, and the child was referred to ICH for further management. There is no history of any sudden increase or decrease in the abdominal distension for the past 15 days. And the abdominal distension was not associated with vomiting, diarrhea, or constipation, or lower limb swellings or scrotal edema. The child had a normal bladder and bowel habits. There is no history of any hematuria or dysuria. There is no history of any trauma. There is no history of any weakness of the lower limbs. There is no history of fever or refusal of feed or loss of weight or failure to thrive. There is no history of any respiratory distress or hemoptysis. There is no history of any yellowish discoloration of skin or the urine. There is no history of any bony swellings or bony pain present anywhere else in the body. There is no history of any altered sensorium or seizures were present. There is no history of any abnormal movements of the eye or blackish discoloration around the eye. There is no history of any skin nodules. On coming to my past history, the child was examined and evaluated for the similar complaints in ICH, and the child has also undergone some invasive procedures and some invasive investigations, and child was on treatment for the same. The child is born by spontaneous conception by non-consanguineous marriage. The antenatal scans were normal. There is no history of any maternal comorbidities. There is no history of any maternal drug intake. It's a firstborn term child born by normal vaginal delivery with a birth weight of 2.7 kg. There is no history of any maternal, any perinatal insults. The child's development was impaired with the age, and child was also immunized in up to his age. There is no significant family history was present. So on summarizing my history, this is a 1-year-old male child who had a complaint of abdominal distension for 15 days duration. Otherwise, the child is asymptomatic, for which the child was being evaluated and some investigations were done and was on treatment. Shall I proceed with my examination?
Wait.
Yes.
Based on the history, what all
Yes,
is coming to your mind as could be the possible cause of abdominal distension in this child? 1-year male who has been incidentally detected to have abdominal distension asymptomatic. Yes.
Yes, ma'am. Yes, ma'am. The child has also undergone some invasive procedures, madam.
No, please. That is what I want to tell. That during
Yes,
the examination, you tend to base your entire this thing on the invasive procedure has been done. You just exclude the invasive procedure and
yes,
think that this child is walking into the OPD with this complaint. Now, what comes to your mind?
My first diagnosis can be any pelvic junction obstruction can be there, madam, because it's the most common thing with an abdominal distension.
Very good. Okay.
Yes, ma'am.
Yeah, right. Then what? Because you kept insisting that the child is well preserved, there is no loss of weight, loss of appetite. Yes. You won't think of a malignancy first off, right? If madam's, I mean, she asked you to exclude the history, the surgical history.
Yeah. So
Yes,
the first thing that comes to your mind is PUJ. That's fairly okay. That's fairly okay. Then next what? Because it can present in a, you said that it is the most common lump. Yes, agreed.
Yes, ma'am.
And it can present in a asymptomatic way as a form of a lump. Now,
Yes, ma'am.
anything more?
1-year-old child.
It can be a.
How do you classify the lesions based on the etiology and then come to a conclusion?
Yes, ma'am. It can be any cystic lesions of the abdomen, madam. There may be a asymptomatic.
You can tell the points for and against. So you said that renal lump, that is, I agree with it. Now come to the next DD.
Yes, ma'am. It can be a mesenteric cyst or a omental cyst, madam, which also will present in 1 year of age without any symptomatic presentation, with only an abdominal distension, madam.
Yeah, but you would expect some GI symptoms if it is that big a mass. Anyway, second,
Yes,
okay. Third.
Any.
You know that based on etiology, we generally, based on the knowledge given on the Kedas and all that, we base the lesion into congenital, traumatic, neoplastic, inflammatory, and degenerative. These are the 5 types. So you said you are already stressing on the congenital because it's a small child, and we expect more of congenital lesion. Renal lump, very good. This is the main, the most common lump. Second, you said is a cyst. That is also well taken. Now, anything more in congenital that you would like to say, or you come to the next pathology, etiology?
I will come to the next etiology, madam.
Okay.
Madam, next. Inflammatory disease, if there is present, there will be associated constitutional symptoms. Any fever will be present. The child is completely asymptomatic.
Okay. So you
let's come to the most common things next.
More common thing.
More
now,
common
for congenital, come to what other things are seen in this this age group.
Other congenital.
Not congenital. You're finished congenital. You've got this pre-existing.
Inflammatory, traumatic sprain injury.
So inflammatory, you are saying that symptoms are not corroborated. Come to the next etiology.
Trauma also there is
unusual for a small child, right?
Yes,
why don't you go to neoplastic street? Why are you?
Yes, sir. Neoplastic
you're ignoring the elephant in the room. Yeah.
Okay. Neoplastic can be at this age group. It can be a neuroblastoma, or it can be a Wilms tumor, or a congenital mesomblastic nephroma can also present.
Yes.
Then any retroperitoneal lesions, there can be rare lesions like the extraperitoneal germ cell tumors.
Very good.
You mean teratomas also?
Yes, sir.
Teratoma.
So yes, sir. Benign lesion germ cell tumors. It can be a benign lesion teratoma or a malignant lesion to a epioxid tumors.
Okay.
Fine. That's
okay.
That's fairly a good diagnostic list. Okay.
Yeah, you have thought
now
of
you can.
things.
So I agree with your first put the serial wise. You said the renal lump because these are the commonest, and besides that, you gave a. Now you come to the examination. Dr. Velmorgan, is it okay? Shall we go to examination?
Yeah. Proceed.
Okay. Now proceed.
Yes, ma'am. Coming to my general examination, after obtaining consent from the mother and in a well-lit room and with good exposure, I started my examination. The cry and activity was good. The child had pallor, no ectric, no cyanosis, no generalized pneumopendopathy, no pedal edema or scrotal edema was present. On examination of vitals, the heart rate is 110 per minute. The blood pressure is 90/60, measured in the right upper limb with the child in supine position, and the child was not crying during the BP measurement. Respiratory rate was 25 per minute, and anthropometric measurement, head circumference was 42 centimeters, which falls between 15th to 50th centile, and weight was 8 kg, which falls between 15th to 50th centile, and the length was the 76 centimeters, which falls between 50th to 85th centile. On coming to the head to foot examination, there is no swellings over the scalp or forehead. There is no abnormal movements of the eye, and there is no blackish discoloration over the eye was present. There is no other swellings present anywhere in the long bones or the body. There is no skin nodules were present. The limb lengths were equal. There is no limb length discrepancy, and there is no muscle wasting present over the lower limbs. On coming to other system examination, the cardiovascular system examination, S1, S2 was heard, no murmurs, and respiratory system examination, bilateral air entry was present. There is no added sounds. On no added sounds. The locomotor system examination was normal. On CNS examination, there is no weakness of the lower limbs. The bilateral tone was normal. The deep tendon reflexes were also normal.
Can I interrupt? No, you said you are looking for skin nodules.
Yes, sir.
You are looking for skin nodules or subcutaneous nodules?
Sir, I'm looking for a skin nodules, sir.
Because that's an important point, because you are thinking of neuroblastoma.
Yes,
Porous.
sir.
So those
yes,
nodules are dermal nodules. Okay.
Yes, sir.
They are not subcutaneous nodules. Okay.
Yes, sir.
Right. Good.
Yeah,
They are skin nodules. That's the right word.
Yes. Okay.
Okay. Yeah.
Shall I proceed?
Then you said you are looking for deep tendon, general examination. You are looking for tendon reflexes.
Yes, sir.
What exactly were you looking for?
Sir, it is an abdominal mass, and it's this age group, I think, more in common of neuroblastoma. So neuroblastoma has a potency to go into the intraspinal extension. Sir. If there is an intraspinal extension with compression of the spinal cord, this is a mass which is present over the abdomen and lower limb. So I think of a lower motor lesion. So it can, the deep tendon reflexes may be absent. Sir.
Okay, how common is vertebral erosion and spinal canal extension in an abdominal neuroblastoma?
Sir, it is not as common as a thoracic lesion. If cervical and thoracic lesion, it is more common.
Cervicothoracics have more propensity to cause a erosion and enter into the spinal canal. Nothing prevents this, but the usual tumor biology is that. Now, yes, if a cervicothoracic neuroblastoma extends into the spinal canal, I mean, what do you, spinal cord and compresses the spinal cord? What sort of, yes, you said here it's a lower motor neuron lesion. What type of, what will happen to the deep tendon reflexes? Especially elicited in the lower limb.
Yes, sir. If it's cervicothoracic lesion, it will be more of an upper motor type of lesion.
Correct.
And they will have a exaggerated deep tendon reflexes.
Yeah. See, this is what PG should learn. If you have got a erosion lower down, it's going to cause only the disruption of the spinal arc reflex. So you're going to have an absent withdrawal or exaggerated when you try a withdrawal or lower deep tendon reflex. Whereas if it's in the cervicothoracic, you're going to have an upper motor neuron lesion, exaggerated tendon reflexes. That is the difference. Okay, proceed.
Yes, sir. On coming
to finish your general examination, you said.
Yes, sir.
You looked at limb. You're mentioning limb lengths and all that you mentioned.
Yes, sir.
What were you specifically looking for?
Sir, for
you're doing anthropometry.
Yes, sir. For limb length discrepancy and anthropometry, I was suggesting of some syndromes which are associated with the neuroblastomas or can be associated with any renal mass. I think of Beckwith-Weidman syndrome. So I thought of measuring the limb length and the discrepancy and weakness and the anthropometry.
Okay. There are one or two things that I want you to mention in general physical examination. That is syndromic faces. Did you find? Because that is also in Beckwith-Weidman. You will have syndromic faces, so you should have commented on that. What about the pigmentation?
Yes, ma'am. The pigmentation can be caused due to two things, ma'am. One is due to blueberry muffins can be associated. Otherwise, in neurofibromatous type 1 lesions can have the skin pigmentations.
But Did you mention it in your examination? I did not hear it actually. So, and
11.
what about the
just
BP?
mentioned.
What about the BP? Does it fall within the normal range for this child?
Yes, ma'am. Yes, ma'am.
Or slightly higher?
Element. It forms within the normal range, madam. The BP is 90/16, madam. For this age group, it
is
should be
slightly
around
higher.
90 is higher, isn't it? I would expect 80/60 or
Okay.
80/50 at
Yes,
1 year. Okay. And you said the child was not crying. The child was not crying, possibly.
Yes, he dogmatically stated so. And then the BP is also sounds to be at a higher limit if it is not beyond the normal this thing, but it is certainly higher.
1 year, I would expect 80/50 or 80/60. Anyway, in a non-crying child. Okay, Raja, proceed.
What do you think would have caused high BP in this child? As per your DD?
Abdominal mass, which is compressing the vessels, renal pedicle vessels, which can cause a decreased GFR, which can increase the renin, and it can cause increased blood pressure.
Then that is one,
That is one reason. What else?
Then what else?
What else?
Neuroblastoma. Neuroblastoma.
If it is a neuroblastoma, the catecholamines also can release, which can also cause a increased blood pressure.
Okay, can hydronephrosis cause a high BP?
If an hydronephrosis is huge, which can resulting in the stretching of the vessel, then can cause the hypertension.
Yes. Okay. Fine. Next, you can come to the local examination.
You would finish the examination of the eye and all that?
Yes, sir.
He mentioned. Mentioned
yes,
something.
Sir. I mentioned about the abnormal. Yes, sir. I mentioned about the abnormal movements of the eyes. For the abnormal movements of the eyes, the syndrome associated with this Wormer's syndrome, which is also called as Skins-Browne syndrome or dancing eye or dancing feet syndrome.
So with what type of lesion is it more commonly associated?
So it's mostly due to the antigen antibody complex, which is causing
what type of
location of the lesion?
Location. Madam wants to know the tumor. Which neuroblastoma has got more propensity for Wormer's based on site?
It's a primary mediastinal neuroblastoma.
Yes, that's fine.
Good. What sort of movements are you looking for in an Wormer's? Do you usually see?
Yes, sir. We'll have an opsoclonus movement, sir. Opsoclonus movements are rapid, multivectoral, unintentional,
multivectoral, right?
Yes, sir. Rapid, involuntary, multivectoral. Yes, sir.
The actual word is chaotic.
Chaotic movements.
Absolutely chaotic. Yes. And what is the hallmark of the movements in Wormer's?
So it will have a conjugate eye movement, sir. Both the eyes will have a conjugate.
The interpupillary distance is always maintained. They are not, they are convergent. Okay, yes. So conjugate movement, both eyes move together. Either vertical, transverse or whatever plane. Chaotic movements, they move together. Okay.
Yes.
Right.
Okay, now tell me, eyes are very important as far as abdominal lump is concerned. What all particular things, and you tell me which conditions you are thinking about and what signs in the eyes will you see?
Yes, ma'am. First, the abdominal movements of the eye for Wormer's syndrome. Then any periorbital blackish discoloration, that is raccoon eyes, that I will think of neuroblastoma, which causes deposits over the orbital venous plexus. Then any aniridia, the eye lesions, the iris, the part of the iris is absent, which can be associated with the WAGR syndrome. Then any heterochromia of iris, which can be associated with the Horner syndrome. Then
with Horner syndrome, what is associated?
Heterochromia of iris, ma'am. Ptosis, meiosis, anhidrosis, and heterochromia of iris.
Okay. And what else? What abdominal mass? What other things? Is any eye signs with Wilms tumor also? Is there? In the eyes? What is aniridia?
Aniridia is absent of part of the iris, madam.
Okay, so it is sectoral, you know about the classification?
Madam.
Classification of aniridia. Okay.
I don't know.
Pass,
Yes.
pass.
Okay. And what are the lesions which can cause proptosis?
Proptosis, any retroorbital deposits can cause proptosis, madam. Especially in neuroblastoma, that can have a retroorbital deposits by orbital venous plexus and can cause proptosis.
What other causes? Tumors only? Proptosis?
Any other tumor, just think laterally, which causes presence of proptosis.
Yes, sir. CML lesions can also cause proptosis. Leukemias condition.
Yes, good. So
Then?
you must understand that even in like exam is different thing, but even in day-to-day practice, you should have a broader view about everything. Don't think you know the diagnosis, then you have to think, because in exam, a viva can go anywhere. So proptosis, you should know the causes, what are the this thing, and similarly different eye conditions, you should be very, very clear about this. Okay. Fine. Dr. Velmorgan, can we go ahead with a local exam?
Yeah. You're too much on the eye. Yeah.
No, it's very good, because most of the time, at least in our exam, 2/3 of the time was devoted to this only, and then very little for the condition. Okay.
On coming to my abdomen proper examination, inspection, the abdomen is found to be distended. The umbilicus was found to be shifted to right and also downwards. All quadrants were moves equally with respiration. There is no dilated veins were seen. There is a scar which was present over the left subcostal region. The hernial orifices were free. The penis was found to be circumcised, and a urethral meatus was found to be at the tip. Bilateral testis was found to be descended. On coming to my palpation, after warming up my arms, I started my palpation. There is not warmth, non-tender, a mass of size 12 cross.
Yes, 1 minute. Your inspection findings are over?
Yes, ma'am.
No, I don't think you said your inspection findings. You went to palpation straight away. We want to know whether the mass, which part of the abdomen the mass is, whether the all quadrants are moving well.
You even said that you are thinking about renal mass, and your inspection findings are over by seeing the anterior part of the abdomen only.
Yes, ma'am. I also inspected the left side of the scrotum or the root of the scrotum. Is there any swelling or not? There is no swellings were present, ma'am. And the renal angle also, there is fullness.
We wanted to know about that also, because it forms a part of it. So once you have thinking about you in the first differential diagnosis, you said renal lump, and then you are not telling anything about renal angle. So that is not taken well. Yes.
Okay. Renal angle fullness was present, madam. And coming to my palpation, it's not warm, non-tender. A mass of size 12 cross 8 centimeters was present in the left lumbar region with extension into left subcostal, umbilical, and left iliac fossa. The mass extends, superior extent is about 2 centimeters from the subcostal margin over the midclavicular line, and inferiorly it extends about 2 centimeters above the anterior superior iliac spine. Medially, it crosses the midline for about 2 centimeters. Laterally, it occupies whole of the flank. The mass has a irregular margin. The margins are well defined, and the surface is irregular. The consistency is hard in consistency. The mass is not moves with respiration, and it is not mobile. It is bimanually palpable, and it is not ballotable. And I can also insinuate the fingers between the mass and the left subcostal margin and the mass and the pelvic bone. The rest of the abdomen was soft, and there is no hepatomegaly was present. There is no evidence of any hernia. The penis was found to be circumcised and urethral opening at the tip. The bilateral testis was descended, and there is no any swelling over the root of the left scrotum was present. The renal angle was full.
Specifically, what are you looking at the root of the scrotum? You said I am looking for any swelling.
Yes, sir. It's a left-sided mass, so I look for any varicocele were present over the root of the scrotum, sir, because the drainage of the left side of the testis goes into the left renal vein, which is directly opposite to the mass and the adrenal vein.
Okay, now there is a question on the chat box, something very relevant. On inspection, you have never, or on palpation, you never mentioned the scar which is there. Again, ignoring the elephant.
Listen, inspection, I told scar, sir.
Okay. Is the mass adherent to the scar? You finished your palpation.
No, sir. No, sir. The mass is not adherent to the scar.
Okay. Then?
Then on yes.
Did you look for free fluid?
Listen, I just completed my palpation. I have to do.
Okay.
In my palpation, I also done a digital rectal examination. The tone was normal and normal fecus staining was present. Then I pass on to my percussion. On percussion, there is a dull note present over the abdomen. The rest of the dull note present over the mass. The rest of the abdomen was tympanic, and there is no evidence of any free fluid was present. And the liver spine was present over the 7 centimeters, which was percussed in the right mid-clavicular line from the 5th intercostal space. On auscultation, the normal bowel sounds were heard.
Okay. Is it over now? Your examination local findings? Are they over? Can you come to some conclusion after that?
Summarize your findings and give us our diagnosis, your diagnosis.
Yes, ma'am. Sir, this is a 1-year-old child presented with abdominal distension for 15 days duration. Otherwise, the child is asymptomatic. On examination, there is a hard mass which is present over the left lumbar region with extension as mentioned above, with irregular surface, and it is not mobile. And I can also insinuate the fingers between the subcostal margin and the pelvic bone. With no other swellings anywhere present in the body. And no other associated syndromic signs and symptoms were present. I like to offer my provisional diagnosis. It's a mass which is arising from the retroperitoneal region of the left side, with the probable site of origin can be kidney, adrenals, or other retroperitoneal structures. My first differential diagnosis is a left retroperitoneal neuroblastoma, and my second diagnosis is a left Wilms tumor. And my third diagnosis is a left extraperitoneal extragonadal germ cell tumors.
Okay. Keeping this, you have come to the diagnosis of hernial.
Why did you say it was retroperitoneal?
Sir, it is a hard mass which is immobile, sir, and it is bimanually palpable. I can't able to exactly examine the plane of the swelling because the mass is huge, and I can also cannot able to shift the child.
The child won't obey commands. How can you know the plane? Okay, I agree with the order in which you said. Your first was a neuroblastoma. Okay. Yes. And was there any other scar other than this?
Sir, one more finding. The child is also had a pallor, sir. So pallor with this in this age group with a hard mass in the left lump. I first thought of neuroblastomas.
Okay, agree.
Okay, you tell me what with the nature of the mass, location, and what other feature in the examination state it could be neuroblastoma. What other points in favor of neuroblastoma?
Yes, ma'am. First is age group, madam. The age group falls, I think, 6 months to 2 years. The child's age is 1 year. Next, the child is having a hard mass in the flank with extension crossing the midline, and it is also a fixed mass. Then the
high
child
BP,
is having a
borderline high BP also.
Borderline high BP, and the child is also paler.
Yeah. Okay. So, and what about the Wilms? What are the points for and against Wilms?
The for Wilms is the child is a well-preserved child, and the age group of Wilms is 1 to 4 years with a median age of 36 months, which also satisfies. then the pallor will not be more in WIMS. In WIMS, the pallor is present. It could be a sudden rupture or intratumoral bleed, which will present as acute abdomen. So it's against the thing.
I won't say so.
Otherwise-
We have so many worms presenting with pallor.
Yes.
Okay, anyway, I take your point. When the
And
child is normal and then the hematocrit drops, then you can think of what you said, a tumor rupture or a bleed within the tumor. Anyway.
okay,
whatever.
but the nature of the on palpation, it is a hard mass, so that also
Yes.
goes. That keeps
Yes, sir.
Wilms has to be a little bit down. Why not
Yes.
congenital mesonephric blastoma?
Yes, ma'am. It can be a congenital mesonephric blastoma, but there is a irregular margin was present. It is
Okay,
not a smooth
fine.
surface. It's an
Fine.
irregular surface. Yes.
I agree that it has to be a better firmer mass rather than a
Yes.
hard one. And what about the
Yes.
germ cell tumor?
Germ cell tumor can be a rare diagnosis. An extragonadal germ cell tumor can present. Most common can be a mature teratoma can present in this age group. The mostly in infancy only the presentation will be there.
So even
But it is a rare.
no, it is a rarer as compared to the neuroblastoma. But
Other two,
about
but it's not uncommon. Not uncommon.
it can be a
Okay.
retroperitoneal teratoma also, which can feel hard.
Yes, ma'am.
I mean, you
It
have to
can.
keep that in. Okay, fine.
Okay.
Now, how will you proceed with
To confirm what you said.
investigate?
They only,
Yes, ma'am.
there's a message, there's another 20 minutes. So
Oh, let's proceed fast then. Okay, fine.
Okay. First, I want to go ahead with a non-invasive imaging investigation. Following the findings of the non-invasive investigations, I would like to do my blood investigations. First, I like to do a plain chest X-ray and an abdomen and pelvis X-ray, followed by an ultrasound of the abdomen and pelvis.
Okay.
now what would you expect to see in an X-ray chest?
Yes, sir. In X-ray chest, first starting from the chest, I want to see any nodules which are present in the chest, and in the abdomen. How is the mass presentation is there? Is there any calcifications present? And how is the bowel gas pattern was present in the abdomen?
What sort of calcification would you expect in
sir, if I my first diagnosis differential is the neuroblastoma, so I think of a spine stippled calcifications.
Okay, fine. It will be a stipple calcification. Now you get a chest X-ray chest and abdomen. You also look at whether it is thoracoabdominal, whether there's widening of the mediastinum at the level of the diaphragmatic domes. You look at the lung fields. You look at the, if possible, if it's a cervicothoracic, you're going to look at the vertebra very closely. Okay.
Yes.
That goes with X-ray chest and abdomen. Then what would you like to?
Then I want to proceed with the ultrasound of abdomen and pelvis, sir. In ultrasound of the abdomen and pelvis, I want to know the site of origin of the tumor and how that mass is involving the surrounding structures and the renal status of the ipsilateral and the contralateral side, whether the ureters were dilated or not, then the nodal status of the patient, and any free fluid was present, and any lesions were present over the livers.
So this is what you are looking for.
Here during these discussions, do you state out the ultrasound finding, its impression?
Yeah, is it on the PPT? Can you put it up?
Sir. So
this is the X-ray of
this.
Okay. What is the X-ray? What does it show? X-ray, can you read it up quickly?
Yes,
because we have very less time now.
Yes, ma'am. This is X-ray of the chest, abdomen, and covering the pelvis. In the chest, I can't able to. The bilateral lung fields were normal. There is no other lesions were found. The cardiac shadow was normal. In the abdomen, there is a soft tissue shadow occupying the left subcostal, lumbar, and the left iliac fossa region. It's crossing to the opposite side. And the bowel gas were pushed to the right side.
Okay.
And
can you
able to find any
calcification? So what is the incidence of pickup rate of calcification for neuroblastoma on plain abdominal X-ray?
Would you prefer this or CT, plain CT?
CT is better for picking up the calcification.
So you should know the pickup rates for both
Okay.
radiological findings as well as for CT. Okay.
Okay.
So what is
You know that?
No.
Okay, pass. Right.
Fine. Next ultrasound finding we have?
Yes, sir.
Please show.
Yes, ma'am. This is ultrasound finding, madam. There is a para-aortic midline mass of 7.8 centimeters, 9 into 8 centimeters, encasing the aorta, IVC, and celiac vessels. The left ureter was encased and with the left UHN, and right kidney hilum and was infiltrated by the mass. And the USG just showed a right minimal pleural effusions.
Excuse me, can you go back to the X-ray now in view of this ultrasound?
Yes, sir.
Can you see right in that here?
Yes,
You said a para-aortic mass. Can you see this here? I have my doubts whether it's part of the mass which is going or it is just an artifact. Okay,
Yeah.
go ahead.
It is giving some sort of an impression like that. Maybe
in view of this ultrasound,
yeah.
I was doubtful previously. Anyway, go back to the ultrasound.
Yes, sir. There is a.
So, based on the ultrasound, which tumor you think is the likely possibility and why?
I think in terms of neuroblastoma, because there is an encasement of vessels were present. So I think in terms of neuroblastoma.
Okay, fine. Why it generally encases the vessels, the neuroblastoma? Where is the origin?
Sorry, its origin from the neural crystals. The neural crystals descends and it forms the parasympathetic ganglions and the adrenal medulla. So the swelling which originates from the neural crystals is more propensity to have the encasement of vessels.
Okay.
How is encasement different from infiltration? What is encasement as defined by, how do you define encasement?
Encasement is the organ is surrounded by the mass and it should surround more than 50% of the circumference, and there should
circumference
be
circumference of that vessel.
Yes, circumference of the vessel, and there should be a plane between the mass and the vessel should be there by imaging. If the plane between the mass and the vessel is lost, it is the infiltrations.
Agreed.
Okay.
Right.
Then next, what will you do next?
Next, I want to proceed with my blood investigations, madam.
Okay.
Thinking in terms of neuroblastoma, first I will do my basic investigations. I like to do my hemoglobin, total count, differential count, and platelets. Then renal function tests and liver function tests. Then specific investigation of tumor markers, like I want to do the serum LDH level and serum ferritin level, and also I want to do the urinary VMA levels.
LDH and ferritin are specific, is it?
Yes, a specific test.
Okay. And for VMA, what would you like to do?
You
said urine VMA. Are you going to do a spot or a 24?
Yes, sir. The spot and 24 hours both gives the same value. There is no difference between the spot and if you want to do a spot sample, I will take a spot sample. Early morning urine sample I will take. If I want to do a 24 hours.
Why that early morning sample?
So it's a catecholamine secreting catecholamine pathway tumor. So during the early morning, the stress levels will be low.
Very good. Very good. So less likely to have stress as a reason for increased metabolites.
Okay. For 24 hours sampling, how do you know how is it collected?
Yes, ma'am. Actually, before collection of 48 to 78 hours before, we should avoid some foods like caffeine, chocolates, or cheese, vanillas, bananas, and some drugs like antihistaminics you should avoid, sulfonamides, which will increase the VMA level, and drugs like decreasing the VMA level, like clonidine and salicylate should be avoided. And the child is toilet trained or not. If it is toilet trained, we should allow the child to pass the urine. After passing the urine, the time should be started. If the child is not toilet trained, I will catheterize the child and discard the urine. And after discardation of the urine, the time will be started. It will be collected in a container which contains 25 ml of 50% acetic acid, or 6 ml of HCl can be used as used. And
You use a weak acid.
And
Okay.
Okay, that's what we wanted to know, that you know the proper method of collection. That's good.
Good. Proceed. Yeah, you know.
Very good. Okay, fine. Next what?
then next.
No, there was a, let us go. There was a, on the chat box, I noted somebody said very correctly that NSC, what about neuron specific enolase as a tumor marker?
Yes, sir, we can do serum neuron specific enolase also, sir, but in most of the centers, it's not available.
Okay,
Yes,
and then,
okay.
and somebody had correctly also mentioned that your LDH and ferritin are surrogate markers. You said they were
Yes, sir.
specific, yes, but they are surrogate specific. Okay, they're surrogate.
Yes, sir.
markers.
Yes, sir. LDH, yes, sir. LDH defines the tumor load and burden, sir, but the serum
Yes.
ferritin is secreted by the neuroblast cells.
Yeah, so it is auto specific.
Okay.
Okay.
Next what?
Next, next, I want to proceed with the staging of the disease. For that, I want to do an CECT of the abdomen and pelvis.
Okay,
Staging
supposing
meaning?
AFP is negative, and so you have a ferritin which is raised. So next you go to, do you have these values or not?
Yes, ma'am.
So what does it show? VMA?
Sir, the VMA is negative, madam. That means it implies it is a poorly differentiated tumor.
24-hour VMA is negative. Ferritin is higher.
Elevated.
LDH is very high. Okay.
Yes. And also anemia is present. Hemoglobin is 4.9.
What about AFP?
AFP levels were not done.
Should have done?
Or you don't know. Possibly it is usually done as a screen. Okay. It's usually done as a screen. I don't know why you're not mentioned it. Okay. Probably negative. I know this case. Probably.
Okay, fine. So that is negative. So what next?
Next, I want to do the CCT of the abdomen and pelvis to stage my tumor to know about the image-defined risk factors.
Good.
So we have the films?
Yes, ma'am.
Please tell. Yeah.
Do you have the spiral or these are
images only, sir?
Can you run the spiral? No. Okay, you have only the images.
Okay.
Yes, sir. Our PAX, there is a problem.
Okay. PAX server. Okay.
You can tell something about that, because
do you have a better film? Do you have a better film?
Sir.
Yeah. And you have a something more?
Recon film.
Okay. We can have this on? Yeah. What is
sir,
your interpretation?
Read it up.
Yes, sir. Yes, this is a coronal section of the chest.
Raja, relax. You're doing well. Relax.
Okay. Yes, sir. It's a coronal section covering the chest and the abdomen and the pelvis, which shows a heterogeneous mass which was present over the abdomen. It is pushing the kidney laterally and downwards. And the right side kidney also is found to be compressed, and it's found to be encasing the major vessels which was found in the abdomen. On the upper part, I can able to visualize the part of the descending aorta, which was also encased by the tumors. And the mass is also extending above into the thoracic cavity.
Yeah, that must be the one that probably Dr. Velmorgan was seeing as a, the mass extending up. Yeah.
Yes, ma'am.
Fine. In axial film, it is not very much clear, no? Because we are not seeing a good pic of that in the CT, axial view, no? Okay.
Yes, ma'am.
And what about the calcification? Are we seeing some calcification? No.
Sir, actually, there is only contrast films were projected, madam. Actually, there is calcification present in the plain film, madam.
So, where do we reach? What kind of, what is the staging now based on this?
Based on this, there is image-defined risk factors for positive. So, according to INRGS, it falls under L2, madam. But I have to do the rest of the metastatic workup to further quantify whether there is metastasis is present or not, madam.
So,
what would you prefer? What would you prefer for a metastatic work?
So for metastatic workup, I want to do an MIBG scan with a bone marrow aspiration and biopsy.
Okay.
So,
Okay. Is MIBG scan that easy?
No, sir.
Would you like to do any true-cut biopsy before going ahead with MIBG?
Yes,
because it is not, it is also not very freely available.
Yes, ma'am. First, I will improve the anemic status of the child and fit the child for anesthesia, and I will do the bone marrow aspiration, biopsy, and an incisional biopsy of the mass with the central line establishment, most chemoport insertion, madam.
Okay. What
All
about...
under the same anesthesia, right?
Yes, sir.
That's what probably they did in unit.
Which route will you use?
So it's a open incisional biopsy will be good, man.
You people don't do true-cut?
Why not true cut? Why not true cut in this case? You've got such a big mass. You'll have easy access. That's what madam is asking about. How would you access this?
Yes, the recommended yes, the recommended thing for true cut is 14 course needle, at least 30 course should be taken, madam. So
it is a huge mass, and you said even the renal angles are full. I'm sure
yes,
it is reaching the retroperitoneal to be accessed from the retroperitoneal.
Yeah, it could be approached from the flank or the back loin very easily.
I think that is very important, because you can do a true cut with lesser. There's no need of open biopsy for this. You can take the sample for true cut. There's adequate sample you can see, and then take the bone marrow aspiration.
Yeah, madam's point is perfectly valid. I would prefer a true cut, but probably I don't know why they did an open. Probably interpretation issues. I think.
Okay. From where will you take bone marrow?
Sir, bone marrow will be taken from the posterior on the iliac crest of the posterior aspect. The better sample.
The posterior superior.
Posterior superior iliac crest. On the bilateral side, you should take 2 bone marrow aspiration and 2 biopsies should be done.
Do we have the report? Do we have the report?
Yes, ma'am. Yes, ma'am.
Metastatic deposits. Okay.
Yes,
NSC is negative.
Negative. There is no evidence of any metastatic deposit they have reported.
Okay. So what about the biopsy report from the tumor?
Yes, ma'am. Yes, ma'am. The biopsy report came a small round blue cell tumor, which is synaptophysin strong nuclear cytoplasmic positivity with chromogranin focal positivity, and neuron specific anolis there is a diffuse strong positivity was present, and the NMIC amplification was also done, which was positive.
Okay. What does the histopath generally shows in such tumors? Neuroblastoma.
Ma'am wants to know what do you expect to see on
histopathology?
Yes,
routine HP.
Yes, sir. In routine HP, first I want to see about whether it is small round blue cell tumors. Next, I want to see about any specific cells like the homocyte rosettes. That is, the neuroblast cells will arrange in a circular fashion in a spoke fill arrangement, which central will be filled with neutrophils, and any scattered neutrophils or mature ganglion cells are present or not. Next, I want to know about the Schwannian stroma is rich or poor. That is, it is more than 50% or less than 50% of the tumor cell. If it is more than 50% of the tumor cell, it goes into good prognosis. So I classify into ganglion neuroblastoma or ganglion neuroma.
Wait. I have seen most of the candidates, they want to spill over the entire knowledge to the examiner. I have not asked you this, na? I am just asking what is the hallmark of a neuroblastoma and histopath examination. You have not told anything about rosette formation, pseudo-rosette. Yeah. That is what I was interested in.
That is what she was expecting.
I told Madam.
You want to tell me the entire chapter that you know about?
No. He said the arrangement, what constitutes the rosette, he said. The neurophils at the center.
You should let the examiner feel important also. Na? You are taking the entire credit to yourself. So that's the way you should be approaching a case. So,
okay. I look for homerite rosettes, madam.
Okay.
Which are
Okay, now,
pseudo rosettes, madam.
okay, with this histopath report, where have you reached?
With this histopathology report, I confirm my diagnosis as a neuroblastoma. Second, that is NMIC positive. Then the bone marrow aspiration was negative for metastatic. Next, there is MIBG scan is not available. So next, my investigation, I will do my PET scan to rule out the metastatic workup. Then I want to risk satisfy the disease, madam.
Okay, but if everything was available to you, then
Then
instead
I'll do
of PET
investigation.
scan, what is
Then
the
I'll do-
investigation of choice?
Then I will do the MIBG scan, madam.
Which
Very good.
which radio tracer?
I will use iodine 123, madam, because it is gives good imaging quality and the sensitivity is around 90%, 92%.
Very good. Good,
Okay.
good, correct.
Once you say NMIC positive, which
Yes, ma'am.
what other things you are? What is it? What does it mean? NMIC positive.
Yes, ma'am. MIC stands for myelocytoblastic cells, which is a master regulator of cells cycle entry and proliferation. So NMIC is positive means it induces the MDM2 and it causes the suppression of P53. So the tumor will have increased proliferation rate, madam. So it is a poor prognosis. Ma'am.
Where is it
No.
located?
It is located in 2P24, madam.
Okay, how much positivity? How much amplification is considered to be relevant to?
More than 10 copies should be amplified.
No. How much of 4 times? That's not problem.
Okay.
Okay, right.
Okay.
So
Okay, now you talked about MIBG, Raja. Now I'll ask
Yes.
you something laterally. Now you have got this bone marrow mets. Okay.
Yes. Sir.
Bone marrow, this thing in
Was negative.
4S. 4S. What
Okay.
will how will the MIBG of
Not
the
available.
marrow in a 4S appear?
Yes, sir. The MIBG should be negative in 4S, sir.
Negative,
But
yeah.
yes.
Negative. It is not since the bone marrow involvement is less than 10% of the in 4S. Normally, this MIBG does not pick it up. If it becomes MIBG positive, you should take it as only 4.
So
Yes, sir.
Okay.
how will you stage the disease now, and what is the risk you will assign to it?
This
based on
particular
these
child
findings.
with all these findings.
Yes, sir. With all these findings, actually the PET findings were there, sir. PET findings showed a metabolic active lesions over the ramus was present. So it comes under M, sir, M stage of INRGS. And in risk satisfaction, it is a M child with the age of the child is less than 18 months. If the NMIC was positive, it comes to O, which is a high risk lesion.
With a metastasis.
Okay.
Yes, ma'am.
Yeah.
If we take that chest one as metastasis, then it is a 4. Okay.
Yes.
So can you tell the broad basis of classification into high risk, low risk, and intermediate risk? What is a broad way to classify?
So if it is NMIC positive lesions, it comes under high risk. High risk, and if it is NMIC
madam wanted
negative,
to know
there are certain criteria laid down based on the stage, age,
yes,
NMIC amplification, diploidy, and
yes,
histological finding. Okay.
Yes,
so what is the
age?
essence of classifying them into various risks? Low risks are?
Low risk are more prone for spontaneous resolution, so we can go for observation, madam. And high risk.
that is low risk or very low risk?
INCSS what? INSS what? Stage 1, 2A, 2B with
yes, ma'am.
Low risk, no NMIC amplification. Is it not? And favorable histology. Is it? That is true? And 4S, you said that since there is a NMIC amplification, he will fall into high risk.
Yes, ma'am.
So, what do you plan to do for this child?
It falls under high risk, madam. So I want to start an chemotherapy for this child. Actual protocol for a high risk is we should start an induction chemotherapy followed by surgery, followed by myeloablative process with autologous stem cell transplantation, followed by the treatment of the residual lesion, madam, if the facilities are available. If the facility is not available, I will go for a upfront palliative treatment with oral cyclophosphamide or oral etoposide, or some intermediate cycle chemotherapy with local radiotherapy for pain alleviation. If the facilities are available, I will go to start off with the induction chemotherapy.
Now this child is only 1 year of age.
1 year old. So what all precautions you will take for?
Yes, ma'am. Before starting my chemotherapy, I'll start the child on allopurinol, madam, to because there is a risk of this is a huge tumor and there is a risk of tumor lysis syndrome. I'll start the allopurinol at 10 milligram per kg in 3 divided doses, 2 to 3 days before the starting the chemotherapy, and I will keep the child in good hydration. Good hydration
Raja,
status.
Can we? I think Vikesh has started this urology. Rapid fire.
Okay. Anyway, his line of treatment is okay. So
yeah, fine.
I think we discussed it in.
I shared the slide. You can take 2 minutes to conclude it. I just shared the slide.
Okay. So now this child, what do you think of the prognosis for this particular child?
Yes, sir. It falls under high risk. According to INRGS, the 5-year survival rate is less than 50%, sir. So it's a poor prognosis, sir.
Would you try to do a bone marrow rescue with a BMT for this child? Would you attempt? If the parent wants to go all out.
Yes, sir. If the parents want to go all out, I will start the induction therapy with Kojak regimen, followed by stem cell harvest, followed by debulking surgery. Then I will go for a myeloablative process with busulfan and melphalan. Then I will proceed with stem cell transplants.
One of our cases last year went for a BMT and it is surviving. Are you aware?
Okay. Yes, sir.
We did a BMT on one of our.
What is the role of immunotherapy and other agents?
Yes, sir. Immunotherapy can be done with rituximab, GM2 ganglioside inhibitor, and also DFMO is available, difluoromethyl ornithine, which is ornithine decarboxylase inhibitor.
Okay. Supposing it was NMIC negative. Now, what you would have thought?
It's a M lesion with a NMIC negative, less than 18 years, and it's also MVIC negative. Then I want to know about the ploidy status, madam.
Very good.
Everything is very good, and supposing that is also hyperploidy. Now,
hyperploidy, then it comes under intermediate risk. So in intermediate risk lesion with a M less than 12 months of age, then I want to proceed with chemotherapy. Chemotherapy, I will start off with a VP carbo for 2 cycles, and I will look for the response. If the response is present, I will continue 2 more cycles of VP carbo, and I will look for the metastatic remission. If the metastatic remission was present, then I will proceed with debulking surgery. If there is no metastatic remission, I will proceed with CADO for 2 cycles, madam.
Okay, if the metastasis was just limited to the liver and the child had a smaller lesion and the metastasis to the liver was very huge, what you would have done? 4S classical with NMIC negative, with everything favorable. Supposing this child, instead of
it is just plain 4S, plain 4S with the large liver. That's madam's question.
Yes, ma'am. Then I will see the age of the child. If the age of the child is
this is 1 year, na?
1 year.
This child only. Supposing tumor was not that large, it was liver which was causing us, and with metastasis, then how you would have approached it? Other factors are favorable.
Okay, ma'am. Then I will go for the Philadelphia staging. The scoring, if it is more than 2 or less than 2, if it is less than 2, I'll just go for observation, madam. If there is more than 2, that is presenting with respiratory distress or lower limb edema or scrotal edema with cardiovascular issues and GIT issues, then I will proceed with chemotherapy with BP carbo for 2 cycles. If the symptoms are not resolution, then again 2 more cycles we can give. Still the symptoms are present, then we can proceed with CADO, madam.
What are the complications with stage 4S with liver metastasis, huge one, huge liver, huge hepatomegaly. What are you bothered about?
First, there can be a respiratory distress. It can be mild distress or requiring oxygenation or ventilation. Second, it can compress the stomach, which can cause emesis and also aspiration. Third thing, it can
abdominal compartment.
Okay. Abdominal compartment syndrome. That is what. And what else?
Madam wants to know how will you manage that abdominal compartment syndrome because of that huge liver.
And what about the coagulation? So these are the risks. With even when there is everything is favorable, the child is going to have a problem, like it may be life threatening, even when the tumor is okay. I mean, it's a favorable type only. So this you should understand. I think you presented it very well, and I'm happy with the way you have presented, except for few things, inputs that we have given, that you should be open to various type of questions. The way the Viva can go in anyway, and you should know every permutation and combination.
The IAPS president wants to give you a medal.
Yeah,
the chat box.
We agree with you.
As we declared last time that there is a prize also on this, which will be given during IAPS Con. So you are being judged also, Dr. Raja. So very well done. And a good discussion always takes time, and your Viva extended a little bit just because there was good discussion going on. So we always encourage that. There is no time limit as such, as so far people are interested in attending. So I should be continuing with a quiz. So far you performed extremely well. So that was a well-prepared case, I guess. Now you get few surprises. So, okay. So it's a rapid fire. You just have to tell the finding and the radiological diagnosis.
Yes, sir. One second. Yes, sir. This is a MCU study, mostly a filling phase. We showed a irregular, the stream is not visible. The bladder neck was up to the level of pubic symphysis, and the bladder contour is irregular. Multiple circulations I can able to see. On the left side, I can able to see the contrast which goes up, sir. But the upper part of the kidney I can't able to see, so the grading cannot be made. It can be a PUV case.
Is there any particular sign visible on this X?
Sir, there is a Christmas tree appearance is there.
So Christmas tree sign is seen in which condition?
Neurogenic bladder.
So why did you say PU valve? So it's a Christmas tree sign.
Yes,
you have got, specifically you have got the descent of the bladder neck you can see beyond the symphysis.
Right.
So in a PUV, you will have a ascent of the bladder base. Here you see a descent of the bladder base. So in this particular film, I would have thought of a PUV first. Okay, right.
So this is also called a spine cone appearance. Okay. Now see this. Tell me what sign is this?
So this is a ADRED sign which is seen in urethrosil, sir.
So it's a antenatal ultrasound showing bladder.
Antenatal. Please be calm. Antenatal ultrasound. You see the.
Give time. Rapid means you don't have to hurry. You don't have to hurry.
Yeah, you got an oblique view of a fetal ultrasound of the bladder and the. What else you see?
Sir, it is a bladder with a dilated posterior. I can see a keyhole appearance.
Yeah, exactly. So it's suggestive of?
Suggestive of posterior urethral valves.
Posterior urethral valve, very right. Is there any other condition you know about in children where you get keyhole sign?
Prune belly syndrome, sir.
Good.
Then urethral stricture or urethral atresia.
Something else? Some head end of the body? Some brain anomaly? Okay. So these are the two conditions you get keyhole appearance. One is Dandy-Walker syndrome, and other is megacystis, like you said, in prune belly, or at times in megacystis. Any reason, any etiology which is resulting into megacystis can result in keyhole appearance.
Okay.
Now see these two films and comment on
why they have been placed together? I mean, what is the reason? What is the difference between two films? And obviously tell the diagnosis also.
Yes, sir. The right side film is it's a MCU study. The right side film is a filling phase. Can you able to appreciate the feeding tube? The posterior urethra was dilated and the bladder neck was found to be elevated and the bladder contour was irregular. There is no any evidence of contrast reflexing. On the film over the right side, it's a voiding film. The stream was poor. The anterior urethra was normal and the posterior urethra was dilated and elongated and the bladder neck was elevated and the bladder contour was irregular with multiple saculations can be seen. It's
now,
a case of PUV.
He asked this question, why are they placed adjacent each other?
Anything to do with the type of the valves? I'm giving you a hint.
It's a type 1 valves.
So that the first film is type 1 valve. You can see negative shadow also inside. While the second film is a type 3 valve, like a diaphragm. Although this concept is a little old concept.
Yes, sir.
So if you see, these are the type 3 valves according to Young's classification. But where it was described that type 3 is like windsock deformity.
Yes,
but this is recent classification, which is COPUM.
Yes, sir. Congenital obstructive post-urethral membrane.
What is the practical application of this classification, this newer classification? This image got from internet.
Yes, practical application, it is actually a membrane which while catheterization, the hole has been happened. That is the.
So what is the practical application, surgical application of that knowledge? So when you do valve ablation, you always look for the thickness of the valve. I mean,
yes, sir. Yes, sir. It will have a more thickness thing, sir. Usually, the type 1 valves will be flimsy, sir. Flimsy avascular.
So, like thickness of the
valves
valve
are generally supposed to be.
Sir?
Yes, sir. Could you please repeat, sir?
You asked me. No, generally, it is as a postgraduate, it is always best to cut what is flimsy and leave what is fleshy.
Yeah.
The more fleshy is it, you are likely to cut the membranous diaphragm and cause a stricture. Okay, stick to the flimsy part. Right.
This one, identify.
Yes, sir. The right film is a MCU study, widening film. The stream was not visible. The anterior urethra was thin. The posterior urethra was dilated and elongated. The bladder neck was elevated, and the bladder contour was irregular with multiple saculations were seen. It is a right-sided reflex on coming to the AP film. The contrast enters a dilated tortuous ureter with dilatation of the calyx was present with loss of papillary impression. So it is a case of PUV with the right side grade 5 reflex, most probably a VURD syndromes.
Very nice. What is the importance of VURD syndrome?
VURD syndrome is one of the pop-up mechanism. It's present. The site which has decreased function, the pop-up will go so that the site which has normal function will be preserved.
Yeah. Seen in 13% of patients with posturethral valve, although that theory is disapproved now because that works till antenatal period. But afterwards, like there is equal brunt to the left kidney because the bladder is not good.
Yes.
What does this film signify?
So the first film is a widening film of a maturating urethrogram in which the anterior urethra and posterior urethra was normal and the bladder neck was also normal and the bladder contour was normal. There is no any reflex of contrast.
Why has he put so many? Why has he put so many?
That's okay. I mean, there's some certain measurement mentioned here. What is the significance of these measurements?
Yeah. Are we looking at something?
Yes, sir. We are measuring the AUPU ratio, sir. Usually the AUPU ratio will be less than 1 in case of posterior urethral valves. If the posterior urethra is more than 6 mm dilatation, it is significant.
So we measure like PU-AU ratio, and if it is like less it's more often related with the adequacy of fulguration. After fulguration, you assess that.
You compare the ratios post your treatment success by comparing these ratios.
Right. Identify the sign.
So dilated posterior urethra.
It's a female patient.
Okay, sir.
The diagnosis straight away there. It's a female patient. What is below?
So it's a vaginal voiding.
Vaginal voiding, don't you think they would have taken a lateral flow?
Okay.
Bladder is also like elongated vertically. Bladder hypertrophied.
Neurogenic bladder.
Yeah, it's a spinning top appearance.
Spinning top urethra.
You may find that finding in many conditions. Usually is a suggestive of dysfunctional voiding.
Okay.
This one.
So,
you should ask him whether they gave something like that.
Sir, it's a.
I give you a hint. You put catheter in this patient to fill the bladder, it doesn't go into the bladder.
So what is D?
Sir, it can be duplication system, sir.
What is commonly there?
There is a
difficulty in intubation. Huh?
Good answers are coming in the chat box, but still no answer for this question.
Any Mullerian?
You put catheter and doesn't go, it goes into that. It doesn't go into the bladder.
You're overthinking.
Sir, it's a clinical anomaly.
It is a
what happens? Prostatic utricle.
Okay.
Okay.
A big
it's
one.
A prostatic utricle diverticulum.
Okay, sir. Okay, sir.
Such a large.
Put a D also there for you.
Yes.
Because of D, he said duplication.
It's okay.
Okay.
Single film, it is difficult to diagnose at times. So such a large diverticulum may cause obstructive symptoms and may need surgery. Usually small diverticulum don't require surgery.
Okay.
There was one interesting fact after that. I don't know why this is stopped. Yeah, there was one more X-ray. I'll show it here. See this X-ray. Can you see?
No, sir.
Oh, okay. 1 second. I'll share the slide again. Can you see this one?
Yeah.
Yeah. There are two conditions. Identify both of them, and there is some criteria which differentiates between the two. Look at the anterior urethra.
Sir, it looks like a diverticulum from the anterior urethra.
A and B. Both
there are two things. There's an angle there.
Yes, sir.
It's not an angle there. You're giving you tips.
What is A and what is B?
Is one a diverticulum?
Yes, sir. Yeah. The A film is a diverticulum, sir.
And a valve, anteurethral valve. These are the two differential diagnoses for such conditions.
Okay.
A is anteurethral valve and B is diverticulum. How do you differentiate
that? Sir, yes, sir.
Yeah. Sir. So it's usually a pseudo diverticulum.
Okay.
In anteurethral valve. So there is intact spongiosa and the angle is obtuse.
Yeah. Okay.
While in a true diverticulum, urethral diverticulum, the angle is acute between the urethra and the diverticulum. That's how you differentiate. That was the last quiz part. Some interesting fact. What do you see here? It's not related to pediatric surgery. It's just interesting fact. So you can see heart-shaped prostate here.
Yes, sir.
The prostate looks
Yes.
heart-shaped, and here you see duct in the liver.
Yes, sir.
So there's one thing called as Rorschach's radiology, where you find funny, unidentified signs on ultrasound. That is called as Rorschach's radiology. So he was a psychiatrist. And there's a very good poem here comparing the two, Röntgen and Rorschach. So it's just interesting fact I came across, so I share. Thank you very much.
Thank you, sir.
And
Thank you, sir.
I'm extremely thankful to both of our examiners for an excellent teaching session today and generating a lot of discussion. Someone want me to repeat what is the difference between a anterurethral valve and diverticulum. So in anterurethral valve, you get an obtuse angle, while in a true diverticulum, you get an acute angle between the urethra and the diverticulum wall. I can share you that article. Whosoever is this can write to me personally. I'll share that article with you. Thank you, Raja. You did a really very good presentation and you answered well. Well done.
Thank you.
I think I must appreciate the IAPS team for taking this initiative of going deep into discussions, and really it has generated a lot of interest and so many people are benefited at the same time. I appreciate both Dr. Ramesh Babu and Dr. Vikesh, and also my co-chair, co-examiner, Dr. Velmurugan.
Yeah, I share the same thoughts. Thank you, Vikesh and Ramesh, for starting this and continuing.
Thank you. Ramesh, would you like to say something? Dr. Ramesh?
Yeah, I want to thank Dr. Velmurugan, Dr. Simi, and Raja for having this very interactive and very good session. And Raja, you did well because the examiners could go up to the last question they can ask, and that shows that you did well. So well done. And exams are around the corner, and a lot of places exams are starting in December, and it goes on up to February in some centers. So I wish all the PGs, all the best for their exams. It's very important that you keep relaxed and then think like normally how you think in your ward rounds. Don't think differently. And both the examiners as well as the candidate know about the case. So you don't have to, feel like something special there. Just be normal like any other day and then behave normally. Then you will all be all right. And I thank Vikesh for adding spice to this discussion at the end. He brings out a lot of, special desserts at the end of the meal, and then it adds the flavor. Thank you, Vikesh. And I think we'll continue with these sessions for at least till the exams are over. And even after that, if the interest is good, we will definitely continue. Thank you.
Thank you very much. Have a good night.
Thank you.